out in 1 minute and less. All right, we finally got it. Welcome back, colleagues and colleagues, back to our international ground. I'm very pleased today once again to have Narayanan Prepageran from Malaysia. Good morning.
Good morning. It's good evening for us, but well, good morning to you guys.
Yeah, sure. It depends on where you're connected. So,
Exactly.
Professor Prepageran is one of the renowned surgeons from all around the world. You already saw him talking about some dissection, some preparation for endoscopic sinus surgery by the meaning of anatomical specimen. Now, we're going to focus on something different, something that we really want to know when we're going to approach to do sinus surgery. So I think that this talk will be very interesting for the residents, not only for the residents, for the juniors, for everyone that would like to approach to this surgery. So I requested to talk about preparing a patient for functional endoscopic sinus surgery. I remind all the attendees to type their questions. If you have any questions, we will reply at your question at the end of his talk. So Narayan, please do share your screens once again, and welcome again to our international equality ground rounds.
Thank you. Can you see my screen now?
You have to share it again because I've interrupted.
Okay, that's fine. No worries.
Great.
So let me share my screen again. There we go. Okay, perfect. Can you see me now? Yes.
Sure.
Okay. Thank you, Puya. Thank you so much for the very kind introduction. I usually give surgical lectures. This is one of the few times that I'm giving the philosophy of surgery itself. And I thought this would be a very nice topic for us to have an overview of how we prepare a patient for FES. And I think it's a very nice topic as well. So what I did was I actually got my fellows and my colleagues to do a literature search on what I thought would be important, on what are the evidence that we have, what do we mean by optical medical management. I wanted my colleagues who are the rising stars in their field to give their feedback and collate all the information that we have together. So I'm going to give an introduction, then let's discuss about the optimal medical treatment. So what is the literature review about preparing someone, the use of steroids, the intranasal steroid spray, the antihistamine, the biologics in preparing a patient for a sinus surgery? I'm not going to talk about the what do you call the classifications, the definitions, and so on. I think all that is completely very freely available, and all of you are experts in that. I'm also going to talk about CT scans, how effective it is in a preoperative value, what is the value, how sensitive it is, and embolization, how useful it is if you're doing surgery with something that is vascular. And of course, I can't leave without showing some cases, and I will show some of the clinical cases that we have as well. So one of the most, the majority or a good go-to paper is the EPOS paper. And I was fortunate enough to be one of the authors of the EPOS paper as well, that has summarized very nicely most of what we are going to say today. So as we all know, the problem with endoscopic sinus surgery is we are dealing with a small operative field that is amplified by an endoscope. So it is an abnormally enlarged view that we get, but we are actually operating in a very small operative field, and any bleeding will affect the surgical field visibility. Therefore, and that will cause obviously a longer operation and more complication. Therefore, in whichever way that we can, we have to minimize the inflammation, the edema, the infection, so that the blood loss or the surgical visual field is optimized during surgery. So what do we aim to achieve? We want to have a very minimized or very minimal intraoperative bleeding and maximize surgical visual field. That is our main aim. So therefore, that gives us safer surgery, a better surgical outcome, and a shorter operating time as well, because less time, more time is spent on doing what is necessary, and less time is spent on hemostasis and so on. So obviously, we are very familiar with this. This is a basic for any surgery or any surgical intervention. Stop anticoagulants, warfarin 5 days before operative, check the INL before surgery. The patient has got aspirin or any platelets, we have to stop them 7 days before surgery. But however, if stopping an aspirin or clopidogrel or any antiplatelets in a patient who's got a drug-eluting cardiac stent can cause problem, it's always good to consult a cardiologist, especially with these medical legal issues that is getting more and more these days. We also have to optimize medical comorbids. We have to be cognizant that cardiac diseases may produce that hypotensive measures during surgery can actually exaggerate the cardiac diseases or stroke. Antibiotics for acute exacerbation. And now smoking. I can always tell the nose of a smoker by the appearance. He's got a velvety red appearance, and the minute you touch, you will have oozing. And I always find that if you ask someone to stop smoking for at least a few weeks before surgery, the surgery becomes easier. You'll always have a persistent ooze and a velvet-like appearance in the nose of smokers. And the good thing is quite a few smokers, once they go to surgery and I explain to them, they actually kick the habit. So it's good to stop smoking before surgery. And it's also good to tell them you may as well have stopped smoking for good. And it works quite well in quite a few patients as well. This is the golden question, the million-dollar question. What is the maximal medical management? We all say that endoscopic sinus surgery should be done only after a maximal medical management. But what is a maximal medical management? And that is what this talk is about. We know it's intranasal steroid spray, antibiotics if needed, antihistamines that is needed, and oral steroids if required. But what is maximal medical management? This is what I asked my colleagues to go do a literature search, and this is what we came up with. Let's go one by one. How about steroids pre-op? Now, if you look at the guidelines there is so far, now the use of pre-operative corticosteroids, it does reduce the blood loss, operating time, and improve the quality of surgical field. This is for intranasal corticosteroid sprays. Now, we will never do a surgery for someone who's got a sinusitis or chronic or CRS without using at least a few months of INS or corticosteroid spray intranasal. Is there a benefit if we add a systemic corticosteroid spray? Now, that is not clear. One of the meta-analysis that was done by Kosla, where he went to 1,148 patients, they found a significant improvement, statistical beneficial than placebo for patients who used a pre-operative steroids. There's a difference of blood loss of 28 ml. Now, let's look at this data. This data shows a double-blinded placebo-controlled trial, which is probably the best that we can have. Let's look from bottom and then go upwards, right? So this is a paper that was published in 2007. It's an oral steroid that was given 30 milligrams for 5 days, and then 30 milligrams for 5 days pre-operatively, and then 30 milligrams daily for 9 days pre-operatively as well. And they compared to a placebo for the same duration, and they found that there was no difference at all as far as the blood loss and surgical field quality. Now, if we go upwards again, this is into 2015, where they used a steroid, 1 milligram per kilogram body weight for 2 days, and then they tapered down to day 10. And then they compared with placebo, and they found there was no difference at all in blood loss or surgical field quality. Look at another paper, 2015 again. Now, this time the difference was, these are all patients with nasal polyps. 60 milligrams daily for 7 days. That means a loading dose of 7 days. Then they brought down to 10 milligrams of penicillin every other day for 8 to 10 days. Identical placebo, 7 days, and placebo for 8 to 10 days. Again, compared blood loss, surgical field, operation time, hospital stay. The results were quite impressive. Reduced blood loss, improved surgical field, decreased operation time, and better hospital stay. So the problem now is that we have 2 papers that's got oral steroids that shows no difference, and 1 paper that shows with oral steroids there's significant difference. So we do not know how much steroids to give. We do not know how much duration to give. The only difference between these 2 papers compared to the first one that shows significant difference is that they had a loading dose of 60 milligram penicillin for 7 days total, compared to the other one, which is 1 milligram per kilogram body weight for 2 days. So is it possible that if you have a loading dose for a longer period of at least 60 milligrams of prednisolone or steroids for the week, only then you get the benefit of the reduced blood loss, improved surgical field? That is something that we need to explore and we need to find out among ourselves. So if you look at the preoperative consensus now, or considerations now, there is no consensus at the moment as far as dosage and duration is concerned. What we know so far is that a 5 days course of 1 milligram per kilogram body weight of prednisolone has got a much better or significant decrease in total blood loss compared to just 1 day. So this is in keeping with the finding that we discussed just now. If you want to give steroids, oral steroids is fine, but you have to make sure that you have a loading dose for at least 5 days before it works. And it works very well in patients of CRS with nasal polyposis. However, to the best available evidence at the moment, the maximum dose of oral corticosteroids in CRS with nasal polyposis should not extend 1 milligram per kilogram body weight per day for up to 2 weeks. How about CRS without nasal polyps? At the moment, it is not recommended. There is no evidence, clear-cut evidence for CRS without nasal polyps at the moment. Let's talk about traditional medicine. In our part of the world, traditional medications are very commonly used, ginseng and the Chinese traditional medicine. Most of them are believed to have anti-platelet activities, and we have seen clinically, when we do skull-base and advanced cases, the amount of continuous oozing that we have. There is no studies at the moment that has got in regards of bleeding risk of FES on patients with traditional medicine. But if you look at some of the publications there are, ginkgo, for example, has got a inhibition of platelet activating factor. Ginseng lowers the blood glucose and also inhibits the platelet aggregation. So this garlic inhibits platelet aggregation, and this may be irreversible. So a lot of patients take ginkgo, take ginseng, take garlic. So if you anticipate the patient's going to bleed, especially the patient's got recurrent acute infections or refractory acute sinusitis, it is a very good idea to stop the patients from taking supplements for at least 2 to 3 weeks before. So when we do complex skull-base cases, if the patient's on garlic, ginkgo, or ginseng, or any Chinese traditional medicine in our part of the world in Asia, we will not do the surgery for at least 2 weeks until the traditional medicines are stopped. How about pre-operative antibiotics? Now, there are possible treatment, of course, for acute infection, infective exacerbations, but so far there's been no studies that has been found with regards of the use of pre-operative antibiotics and its relation to surgical field and blood loss. There are studies about post-operative antibiotics, and if I remember correctly, there is no evidence of the use of post-operative antibiotics as well, as far as endoscopic sinus surgery is concerned. This is an interesting paper. How about intranasal desmopressin? Now, desmopressin is like vasopressin. So it's got a hemostatic effect by raising the plasma concentration of coagulation and one relevant factor. And there's a randomized control trial by using desmopressin into an intranasal desmopressin. And there is a significant effect on the reduced blood loss and the improved quality of surgical field. And you can see the data very nicely presented here. This is the control, this is desmopressin, and you can see the reduction of bleeding in bleeding, the amount of blood loss, 15 minutes, 3.9 compared to 5.6, 30 minutes, 3.8, 5.7. And look at the amount of the quality of visual field as well. So there is evidence at the moment to show that desmopressin actually does decrease the bleeding if used intranasally as well. Let's talk about patients with chronic rhinosinusitis and nasal polyposis. So let's see, as far as intranasal corticosteroid is concerned, there is very high quality evidence that long-term use of INS is definitely effective and safe. And I think none of us will operate if there is no, if the patient is not been using INS at all. It improves nasal symptoms, quality of life. It reduces the nasal polyps, and it does not affect the intraocular pressure or lens opacity. So therefore, the steering committee advises the use of INS in CRS, as we see. How about combining both the intranasal steroid spray and the oral prednisolone is it more effective than using only the INS in improving the size of the polyps, the nasal airflow in nasal polyposis? So a short course of systemic corticosteroid, either a week or 3 weeks, with or without local corticosteroid treatment, it does help in a significant reduction in a total symptom score, nasal score, as well as a nasal polyp score. And you can see this very clearly in this graph here. All the 4 study groups have showed that a short course of nasal steroid, oral corticosteroid in patients in CRS with nasal polyposis has got a very good effect as far as the reduction of symptoms. However, it's only recommended to use 1 or 2 systemic courses per year as a useful addition for partially or uncontrollable disease. But the mainstay of treatment is, as usual, is the intranasal corticosteroid spray. How about antihistamine? We use antihistamine very, very frequently. Now, does it work? Is it useful in treatment for rhinosinusitis with and without polyps? Now, there are the papers evaluating atrophy as a risk factor for CRS are conflicting. Some of the papers, for example, by Hay, double-blinded placebo-controlled trial, 45 patients with CRS with nasal polyposis, cetirizine versus placebo, no difference at all. So there's no direct evidence to show that antihistamine reduces the polyp size, and there's no difference whatsoever with the total symptom score compared to a placebo. As far as the use of antihistamine with the patients for CRS, there is insufficient evidence, and there is no literature search from the literature search. There's been no papers found whatsoever with regards of the use of antihistamines to increasing the surgical field or blood loss. How about anti-leukotrienes? Montelukast, there is some amount of data which is limited as far as anti-leukotrienes is concerned with CRS with nasal polyposis. There's been a meta-analysis of 3 studies evaluating the addition of montelukast to the INS for 8 weeks. And from the data, as we can see, these are the 3 main groups. The data shows that there is no significant benefit by adding montelukast to the INS. And do they help as far as surgical field or blood loss? There's been no papers on literature. So these are areas that we can explore. For the young residents, these are the areas that you can explore and you can do study on. There's been no papers on the use of antihistamine as far before surgical field and blood loss. There's been no papers on anti-leukotriene as far as surgical field and blood loss as well. It's for you guys to do this and publish in the future. How about intranasal decongestants? People use this very often. It has got no effect on polyp size. Again, this paper was published in 2006, and you can see the effects comparing with nefazolime, epinephrine, saline. No changes at all. So there's no difference as far as the polyp size is concerned with the use of intranasal decongestant. So I think all of us will agree that intranasal decongestant, the only role it's got is just a symptomatic relief. Do not use it for more than 5 days and only use it for a very short period, maybe immediate post-surgery, but it's got no other therapeutic value as such. How about nasal saline irrigation? The evidence shows that the nasal irrigation with isotonic saline is effective in the CRS. However, there is no evidence to show that the hypertonic saline is more effective than isotonic saline. There are some low evidence that a large volume, 150 ml saline irrigation, has got some benefit as well. How about adding an antiseptic, mucolytic, a baby shampoo into a wash? There's little or no differences, however, with significantly more side effects. These are papers that's been published in 2016 and 2013 as well. This is an interesting one, something that I found quite interesting. An addition of xylitol, which is a natural sugar that's found in plants. Apparently, by using xylitol in saline, it reduces the nasal symptom score and a visual analog score as well. And these are papers that's published in 2017 and 2011. Biologics. There's been a lot of talk about biologics at the moment. Now let's look at the evidence of biologics. Now we know it's expensive. We know that the major issue, especially in Asia, is cost, especially in where patients have to pay for their own medication. So now, if you look at the EPOS guideline, the main criteria, at least 3 of them must be fulfilled. And usually these are patients who've had surgery. There must be evidence of a type 2 inflammation, basically eosinophilia, either in a tissue or a blood eosinophilia or a total IgE. And there must have been use of oral corticosteroids, at least more than twice a year or a long term. And there must be a significant impairment of quality of life or loss of smell or comorbids of asthma, which means that the criteria or the indications for biologic treatment for patients with CRS with nasal polyposis are towards patients who've got refractory conditions, those who do not respond well despite surgery and despite penicillin. In our part of the world, cost is a major issue. Let's look at it one by one. Anti-IgE, omalizumab. So there are 2 RCTs so far comparing with placebo, and they show improvement. There's a lower symptom score, reduction of polyp size, and improvement in Lund-Mackay scores as well. And if you look at anti-IgE, there's insufficient data at the moment, but this may be for anti-IgE, but in the future, there might be more publications and more papers. Let's look at anti-IL-5. Now, the IL-5 is noted to be elevated in nasal polyps tissue. It's also essential to differentiate final differentiated into a eosinophil. So effectively, if you use an anti-IL-5, you're actually stopping the cells or whatsoever from becoming a eosinophil. So, for example, is mepolizumab. I find it very difficult to pronounce this name. I'm not sure what you guys feel. Anyway, if you look at the published data so far from Bakar, there is significant improvement in both VAS score, SNOT-22, and nasal polyposis severity. Another study is this interleukin-4 or IL-4 and IL-13. They're both potent type 2 immunity, and these are monoclonal antibodies which has been approved for CRS with nasal polyposis. However, it's by subcutaneous injection. And again, the RCT with 60 patients shows significant improvement with SNOT-22. Whether these are going to be the treatment of choice in the future, it's left to be seen. Monoclonal antibodies, so far, none of them have been used as studies to see surgical field or blood loss. Again, these are venues for you guys to do in the future. I also wanted to spend a bit of time to talk about how to reduce bleeding intraoperatively. What is the evidence? Simply because if you have a clear surgical view during surgery, then the surgery is faster, quicker, easier, without much complication. So let's talk about patient positioning, TIVA, and also antifibrinolytic activity. So we all know that you must use reverse Trendelenburg position. It reduces central venous pressure and decreases bleeding. But what are the evidence? If you compare with horizontal position and the reverse Trendelenburg, the evidence shows very clearly. This is the horizontal group. This is the reverse Trendelenburg, and you can see the amount of blood lost is significantly lower in the reverse Trendelenburg group, 750 ml in the total blood loss in the horizontal group, and the reverse group is 369, literally half of it. The surgical field is also significantly better. Now, if you look at the meta-analysis, horizontal position or reverse Trendelenburg, this will convince you simply because all the 3 trials in the meta-analysis shows a significant reduction that favors reverse Trendelenburg position. So again, reverse Trendelenburg, but how much? How many degrees? Interesting question. So this has been also studied both on the visual field as well as amount of blood loss as well. So they compared 5 to 10 degrees, 5 to 20 degrees, 10 to 20 degrees. And if you look at the blood loss, and the difference is significant. Therefore, FAST is best done in a reverse Trendelenburg of 20 degrees position. It gives you the best surgical view and the lowest blood loss as well. How about injection of local anesthesia during surgery? Does it make a difference? So most of us at one point or another will inject a vasoconstrictor directly, usually adrenaline. And let's look at what are the data at the moment. A prospective double-blinded randomized placebo-controlled study. Infiltration with adrenaline and normal saline. And both of them were at the anterior buttress of middle turbinate. The verdict, no significant reduction on intraoperative blood loss or surgical time. Interesting. I would have thought it actually reduces, but it does not. There's no significant reduction whether you use a adrenaline or you use normal saline and injecting to the anterior buttress middle turbinate. But I'm sure there'll be a lot of surgeons who will disagree with this. But what the evidence shows is that an injection of preoperative local anesthesia into the greater palatine canal does reduce the intraoperative bleeding, and the concentration of 1 to 80,000 adrenaline is most effective. How about topical vasoconstrictors? Cocaine is an excellent vasoconstrictor. We have problems in getting cocaine. I'm not sure how it is in your part of the world. And again, randomized control trials shows that 4% of cocaine is as effective to 1 in 1,000 adrenaline. There's no difference between cocaine and 1 in 1,000 adrenaline. So if you don't have cocaine, use 1 in 1,000 adrenaline, you will get the same results anyway. And again, comparing the dilution of adrenaline, comparing 1 in 2,000, 1 in 10,000, and 1 in 50,000. Again, you can see the amount of milliliters of blood loss. And you can see the amount of blood loss, the maximum blood loss in 1 in 2,000, 270, it becomes 3 times more in 1 in 10,000 adrenaline, and it increases almost 5 times more in 1 in 50,000 adrenaline. Therefore, the more concentrated the adrenaline is, the better your surgical results, and that's the lower the amount of blood that you lose. This is common sense, but it's good to see it done in a proper randomized trial, randomized control trial with evidence as well. So anesthesia, I think all of us are very familiar with TIVA. TIVA decreases the cardiac output, is a total intravenous anesthesia, and it shows that a significant reduction of blood loss. And this was also analyzed by Kostler, and they found a TIVA is statistically superior to the conventional inhaled anesthesia with a difference of blood loss of 75.3 ml. How about hypotension? Yes, hypotension is effective, but however, we have to be sure that we use it only on the right patients. Someone with cardiac issues can have detrimental effects of hypotensive anesthesia. This I thought was an interesting paper. Tranexamic acid, a meta-analysis of a tranexamic acid where they compared 7 studies, analyzed 10 to 15 milligrams per kilogram bolus versus saline. And they found, interestingly, that both operative time and the intraoperative blood loss was statistically lower, the treatment group compared to the placebo group. And the quality of the surgical field was statistically higher. So this is something interesting. So this is something for us to consider. So we can use tranexamic acid in doing surgery and with good results as well. And this shows the difference in blood loss, in the intraoperative blood loss by using tranexamic acid, and you can see how significant the results are. All the studies shows towards favor the treatment by using tranexamic acid. Something for us to consider. Embolization, does it make a difference? Now, interesting. The studies, we would have thought that if you embolize for any JNAs or whatsoever, you will get better results. But if you look at the published data, without embolization, you will lose around 5 liters of blood. But with embolization, it's 1 liter of blood. Results are good. But the benefits are only for larger angiofibromas. For smaller angiofibromas, the benefits of embolizations is less clear-cut. And again, if you look at the blood supply, the bleeding compared from ECA, tumors with blood supply from ECA, compared to tumors with the blood supply from ECA and ICA, and obviously the difference in blood group is statistically significant. There's much more bleeding if a tumor is being supplied by ICA as well. Now, should we embolize selectively the ICA branches? To cut a long story short, there is no increased benefit by embolizing the branches of the ICA. Let me go through very quickly about CT scan. Now, one of the things I asked my guys to go through is CT scans, how accurate it is for the diagnosis of CRS. Now, this is a published data to show that a CT scan, if you take a Lund-Mackay score greater than 2 as abnormal, CT scan has got a sensitivity of 94% and a specificity as for 41%. So it's sensitive, but as far as specificity is not so great for a diagnosis of CRS. If you compare the correlation between a nasal endoscopy and a CT scan, you will find that a nasal endoscopy's correlation with CT scan is very good. However, an abnormal endoscopic finding has got a direct correlation with the CT scan finding, but a normal endoscopy does not assure a normal CT scan. So you can have a normal endoscopic examination, but the CT scan will show you abnormal results as well. So which calling system for CT scan is the best, Kennedy or Lund? And according to the study by Bhattacharya, the Lund-Mackay system exhibited the best correlation system between the nasal symptom score and the CT scan in the CRS stage. We always find incidental findings in CT scan. So what are the common, how often do we find incidental findings, and what are the common ones? So a prospective analysis of 666 patients, and they found abnormality or incidental abnormality. These are patients who are not going for sinus surgery, and they found 42.5% of incidental findings in CT scan. Now that's almost half of the patients of scans shows incidental finding. And the most common one is a mucosal thickening in the ethmoid sinuses, which is the most common one. Therefore, again, a diagnosis of sinusitis or rhinosinusitis is a clinical diagnosis. It's not an imaging diagnosis. Therefore, we need a high correlation between a CT scan and the clinical examination that we do. So again, does a CT finding equate to patient symptoms? Now, this is quite interesting. Many studies have failed to show a significant correlation between CT disease specific healed quality of life, and there's no correlation between SNOT-22 and CT scores before and after surgery. And again, there is no correlation between Lund-Mackay and SNOT-22 scores. So these are very interesting and gives us the perspective. The CT scan is just a complement. It complements your clinical finding. It does not give you a diagnosis. It doesn't interpret the quality of life. You should always use your clinical judgment whenever we come to the CT scan. So let me go on to the clinical part, what we do, the instruments we use. So some of the steps I'm going to give it to you are published in a FES manual that was done by my fellow a few years ago, Dr. Yves Ban, who's now the chairman in KUL. And this comes with videos and surgical steps as well. If any of you want this, if you just tell Puya, and I'll be happy to share the entire manual with you guys, and it comes with surgical step by step as well. So these are, what do you look for at the CT scan before performing a surgery? Again, I'm sure you've all heard of the closed system, the cribriform plate, the carotid artery, the lateral lamina, the orbit, the Ono-D cell, S for sphenoid sinus, E for ethmoids. And this, you can see the cribriform plate, the lateral lamella, the nipple, the anterior ethmoidal artery, the lamina papulosa, the carotids, the Ono-D. Whenever you have a vertical shelf here, a horizontal shelf in a sphenoid sinus, then you know you have an Ono-D cell. So this is what you look for in a CT scan before, but I'm sure all of you are quite familiar with this. But again, just to emphasize, before you start the surgery, what do you look for? Make sure the consent has been signed. It's very easy in the excitement of the surgery, in the hustle and bustle of our life, the phone call goes off, the nurses call you from the clinic, they're calling you from the ward. It's very easy for you to forget the consent. Always make sure you look at the consent, make sure the patient has got no medical conditions. Always look at the CT scan before surgery. If you don't have a scan in the operation theater, don't operate. don't start the case. Always make sure the scans are in operation theater. Throat pack when the patient is intubated. And the way we operate is we always make sure the patient's head is slightly extended. This makes surgery easy, especially if you're looking for the orbit in the frontal. Never operate like this. Never flex the patient's head, because this makes you operate looking up and makes it much more complicated as well. So what I do is when the patient is tubed, immediately I spray the patient with cofenilacate and then pack the with ribbon gauze, 2 on each side blindly. One goes along the floor, one goes between the middle tablet and the septum. So this is done blindly before we even scrub, just after intubation. Then by the time we scrub, we come and drape, flap the patient, put a camera system. It's almost 10-15 minutes, and you take out the ribbon gauze, and then we pack. This is how we pack before we even drape. Then we can pack the middle meatus directly under vision, and that gives us a very nice hemostasis. I do not infiltrate the attachment. I do not infiltrate the uncinate. This is what I do, and I get very good results with this, not only for sinus surgery, but also tumor surgery as well. Let me go through very quickly 3 clinical cases. Puya, do I have another 5 minutes? Again,
we have 5 minutes left.
Sure, perfect. So let's look at this case that's got a CT scan in 3 different planes. Interesting case. This patient has had FAST done somewhere before in 2013, and he has got a left orbital injury with a middle rectus injury, and now he comes with a fistula. There's a discharge on the left eyebrow here. That's all his symptoms are. So we know that he's got a dura and orbital dehiscence. Now look at this. You can see that if you look at the scans, it shows you how a correlation of the CT scan would be like. You can see that there is a dehiscence here, the dehiscence here as well. And if you look at the axial cuts, again, you can see where the injury to the orbit has been. This here, that's the injury to the orbit. There is the dura that is dehiscent in the frontal sinus as well. So what I wanted to show you is to be able to look at the 3 cuts of the scan so that you can use all the 3 cuts of the scan, axial, coronal, sagittal, to build the model in your head. Now with this, you can see very nicely the dehiscence at the posterior table of the frontal sinus. You can see that there's a scarring at the opening of the frontal recess, which means the previous surgeons have caused a total scarring and fibrosis there. And also you can see the fistula where it's broken through in front as well. So this is the pre-surgical view. You can see the total scarring of that's the orbit. The orbit that is dehiscent, because remember the patient has got an orbital injury in 2013. And after packing, that is the orbit with hemostasis. There's orbit exposed all the way to the top. There's a total obliteration of the frontal recess as well. Scar tissue because the previous sign. So what I'm going to do is I'm going to elevate the mucosa at the frontal recess like an axillary flap. I'll go a bit quickly in view of time. Then by using a Carrison punch, we can enter the frontal sinus quite easily. And this shows us the content of the frontal sinus. So this came back as keratin. So it's actually a cholesteatoma of the frontal sinus, a dermoid cyst, simply because the previous surgery has obstructed and closed the entire frontal sinus with keratin accumulating. Very interesting. You wouldn't have thought of this until we open up to see. Interesting. And here you can see how we are going to use a specialized suction. That is the removing the matrix of the keratin. This is the keratin being removed from the dura. There's the dura coming into view. There's the posterior table that is dehiscent, and we're removing the keratin from the posterior table as well. That's the dura coming into view as well. And now we are removing the matrix of the dura all around from the posterior table. So this is the final view of the surgery itself. And then we put a stent into this. If this does not work, we will do a lotop for this patient. Another interesting case, it's a patient who's a GP who's been having a mucopurulent nasal discharge for more than a year. Now, doctors make the worst patients, as you know. And what makes it worse, that his cousin is also our new anesthetist. So double whammy, doctor's family. So if you look at the scans, what makes the scans interesting is that you will find that the entire maxilla is opaque. Bone thickening, long-standing infection, air in the center, that means the mucosal thickening. That's the fistula. So this is the main cause. But you need to repair this. This is another scan I wanted to show you. Can you see how it's bulging? If it's bulging like this, a lateral wall, that means it's under intense pressure inside. These patients will usually always bleed because they have a persistent infection. So what I did for him was, you can see the bulge very nicely in the fistula here. So I just admitted him for Zinasef, 750 milligrams 2 days before. And this is the pre-operative view. Again, we were not even able to pack the middle maters nicely because look at the edema. That's the uncinate process that is so edematous that is occluding the entire osteometal complex. That's the pus pouring out, and he's been having this for the past 1 year. So again, look at how edematous the uncinate process is. So we are now removing the tail of the uncinate process. You can, by using a debrider, opening up the uncinate process. This is by admitting him 2 days prior with antibiotics, I found that it was much easier to control the infection. Then it was quite easy for me to enter the maxilla and then use a ribbon gauze with adrenaline. And now I'm already inside the maxilla, and then remove the granulation tissue and enlarge the maxillary opening. As you can see, you will definitely have bleeding. 1 year of infection with self-treatment with antibiotics. And then I use a ribbon gauze to remove all the granulation tissue from the maxilla itself. And this is now, and remove the granulation tissue from the maxilla. That's how large the maxilla is, and remove the granulation tissue from the maxilla. And the surgery goes quite well. So antibiotics, acute on chronic infections, 2 days of IV antibiotics works very well. And we did the surgery in less than 20 minutes because of the antibiotic and the way we packed. Last one. Someone who's got a spindle cell hemangioma in the skull base. It was managed in another center and was said to be inoperable. Had profuse bleeding. They did multiple angiogram, embolized I think 3 times until and then I was asked to come to operate. So I told the patient, I told them, let's get an embolization the day before. So this is the pre-operative embolization. You can see how extensive the spindle cell hemangioma is. There's a pre-embolization view. And now let's look at the coronal view. You can see how the dura is dehiscent, frontal sinus is involved. It's a huge, huge tumor. He was embolized 3 to 4 times before they invited me to operate. Again, you can see how large the tumor is. The dura is decent. The orbit is compressed on the left side completely, filling up the entire nasal. So I told him to embolize 1 day before I came to do surgery. And this is post-embolization. You can see now the vascularity of the tumor has decreased quite significantly. So this is post-embolization. Obviously, the tumor size is the same, but it's much smaller as well. So this is the view before surgery. This is the pre-operative view. And you can see how there's so much of scar tissue because of embolization. This is the septum. The scope is on the left side. There is no landmark whatsoever. The entire nasal cavity was just cyanic case between septum and lateral nasal wall. And this is the distorted anatomy with no landmark whatsoever. So I'm going to skip some steps in view of time. Now we are going to dissect the tumor and identify the periorbital on the laterals on the left, and that's the periorbital being exposed on the left, as you can see. Teasing the tumor away from the periorbital and identify the periorbital on the left, as you can see here. The same way, now we're going to dissect the tumor from the dura. We're going to push the tumor down and then dissect the tumor from the dura. That's the dura being identified. And now the tumor dissection from the dura itself. So all this, you can see it went quite using a ribbon gauze. Dura is being identified. That's dura coming into view. And we're going to now dissect the tumor from the dura. As you can see, that's the orbit on this side. And there's a tumor being dissected from the dura very nicely, as you can see, with hardly any bleeding, simply because I embolized 1 day before. Tumor from the right side, and this is the tumor removal. There's a tumor finally cutting from the dura and the orbit. There's the orbit here. There's the dura. And now the tumor has been finally removed, as you can see. And this is the final view of the surgery. Maxilla. I'm going to go a little bit quickly in view of time. Nasopharynx. It's a sphenoid sinus. And that's the periorbital. This is the periorbital on the left, periorbital on the right, orbit left, orbit right, and that's the dura. of the entire frontal sinus. So this surgery took us around half an hour, and we lost less than 100 ml of blood simply because of the embolization that we had. So I just wanted to show you that in selected cases, embolization works very well. This was a spindle cell hemangioma. So in conclusion, do we use pre-op intranasal steroids? Yes, everyone. Do we use pre-op systemic steroids? With nasal polyposis? Maybe. Without nasal polyposis, CRS without nasal polyposis? No. Combination? Yes, for nasal polyposis. There is evidence to show that intranasal desmopressin works. There's evidence to show that nasal irrigation isotonic works. Reverse Trendelenburg 20 degrees, TIVA, tranexamic acid bolus, intraoperative, topical adrenaline 1 in 2000, greater palatine block. So these are the evidence for preoperative preparation for FES. However, you must individualize every case based on your surgical expertise. Don't overdo the surgery, because you can always redo the surgery, but you can't undo. So always make sure the FES is done appropriately and just enough exposure. You can watch some of the dissections we have on this. And with this, Puya, thank you very much for the invitation, and I'll be happy to answer any questions as well. Thank you.
Thank you, Professor Prepageran. It's always a pleasure at a glance, all information needed for a pre-operative assessment of a patient. If anyone interested for the flow chart and for the scheme, as previously said from Prepageran in regards to the manual, we will be delighted to provide you. So just send us an email and we will reply to that. Thank you, Prepageran, for being with us. I'm sorry we are running out of time, but of course you will be present in the next semester. The announcement for the upcoming faculty members is going to be 1st of March. You will be excited as well. So thank you. You are the last one for this semester, and it's always a great pleasure for staying with us and be part of our international ground rounds.
Thank you. Thank you very much.
Stay safe and check out our YouTube channel for the upcoming meetings. Bye-bye.
Bye-bye.